So this morning I want to talk about stress echo and an assessment specifically of CAD. And we'll also go do a bit of an overview both of the older guidelines and more recently the 2020 ASC guideline. So we'll review some of the indications, the contraindications to stress echo in relation to CAD, some of the best practices and protocols for stress echo as described in the ASC guideline. We'll classify and interpret the various myocardial patterns of response to stress, as well as important prognostic factors when interpreting these stress echo studies. Just a very quick background, stress echo dates back to the 1930s when Tennant and Wiggers originally observed this relationship between ischemia and rapid and predictable development of systolic bulging or dyskinesis. And they found that in the absence of flow-limiting disease, you typically have an increase in your heart rate, your contractility, wall thickening, and endocardial excursion, all of which results in a decrease in your end systolic volume and an increase in your LV ejection fraction. And if you have an absence of this hypercontractile response, then that should be considered an abnormal response. So in 1979, there were two groups of folks who helped spark the stress echo as a modality. So Mason et al. Used M mode and studied about 30 patients or so, noticed that there were stress-induced wall motion abnormalities in various segments that correlated with patients who had significant stenosis of those coronaries. And obviously that has many limitations. Using M mode to try to assess changes in wall motion is challenging. But a separate group, Wan and colleagues, applied early 2D and determined that you could actually have inducible wall motion abnormalities when you did bicycle exercise. And those wall motion abnormalities would reverse after you had revascularization, after the patients underwent revascularization. And that was sort of the first time that we began to understand stress echo and its uses. The primary issue at that point, though, was they were still using videotapes to try to understand echo, and so there was major limitations of how precise they were. But in the 1980s, that's when you sort of started to have digitization of echo images, and it allowed for side-by-side comparison, which obviously improved the accuracy significantly. And since then, the primary technological advancement has been the use of contrast, as we'll talk about in a second. So just briefly kind of chatting about the ischemic cascade, as we all know, you first have normal myocardial blood flow, and then you end up having a decrease in your perfusion, which precedes metabolic abnormalities and cellular changes. Then you have diastolic dysfunction, which you can detect also with stress echo. But the primary role of stress echo comes in right afterwards when that progresses into causing changes in wall motion abnormality and systolic strain. Now that stress echo is advancing, strain is becoming more apparent to us and might be an early marker of ischemia, and we'll talk a little bit more about that later on. But that's kind of the forefront of stress echo in the future. And all of this precedes ECG changes and symptomatic angina. So stress echo has a lot of different uses in CAD, in assessing valve function, in diastolic dysfunction, low flow, low grade AS, and confirmation of that, in structural cases such as hypertrophic cardiomyopathy, but also an assessment of pulmonary hypertension and early detection of symptomatic pulmonary hypertension. But in this, in today's talk, we're going to focus mostly on CAD and briefly chat about viability as well. So just quickly diving into the indications for CAD, these are the updated ASC 2020 guidelines, the class 1 indications specifically focusing on CAD. So they recommend a stress echo for any patient that's suspected to have CAD and have an intermediate pretest probability, whether or not they have normal or reduced ejection fraction. They also recommend it for atypical symptoms at a high pretest probability, particularly high pretest probability or patients with HFrEF or reduced ejection fraction, suspected CAD with resting ECG abnormalities that preclude them from doing a GXT, or if their GXT was inconclusive, this would be the next step. It's actually particularly helpful in patients who have left bundle branch block resting, because as we'll talk about in a bit, SPECT is not the best test for that, and stress echo has greater specificity in those patients. In women, again, it's been shown to have better specificity, and also obviously the direct benefit of not having radiation, particularly young women or women who are pregnant. Patients who have had prior revascularization and are now having new cardiac symptoms, risk stratification in patients who have an inconclusive GXT, or if patients have known CAD with deteriorating symptoms. And then just a caveat, there's also a classical indication that you can proceed to a dobutamine stress echo if the patient, for whatever reason, is unable to exercise. Then obviously you can use stress echo in that setting. I'm not going to talk too much about this, but there's a clear list of contraindications to stress echo, the absolute ones on the left and the relative on the right. The primary ones to remember are patients who have any sort of unstable cardiac or aortic condition, if they are in decompensated heart failure, if they've got having ongoing angina or recent ACS, if they have an uncontrollable cardiac arrhythmia, or even if they have very significant hypertension that is unable to be controlled, that would also be a contraindication. Apart from that, even things like heart block or symptomatic hypertrophic cardiomyopathy are all just relative contraindications. So done in the right setting with the right amount of monitoring, you could still probably get useful information. We all kind of know this pretty well. The two most standardized protocols that we use for treadmill are the Bruce protocol on the left here, where every 3 minutes or so you will increase the grade and the speed, and that correlates with the increase in the METs from 5 all the way to 20, and it continues on. And then the most common supine bicycle protocol, there are variations of this, but every couple of minutes, again, you have an increase in your resistance to the revolutions. And the patient is encouraged to pedal at about 60 revolutions per minute, so 1 per second. Obviously, they can go up and down depending on how fit they are, but that's the general recommendation. And that's if they follow 60, then you can follow this table and correlate METs with their ones. You want to record the amount of workload and the percent of predicted workload that the patient has achieved. And it's important to keep in mind if the patient is unable to achieve 80% of the predicted workload, then that actually dramatically reduces the sensitivity for ischemia. So that makes it a very non-diagnostic test. I know some labs also use 85%. That's from prior studies of GXT. But 80 to 85 is what we need to achieve to have a relatively good sensitivity. And then for both exercise and in the past exercise testing, they had used atropine, and that's as a way of when the patient reaches a certain amount of heart rate, they give atropine at the end just to see if their heart rate will continue to be maintained at a specific heart rate above the 85% rate. And that's because in treadmill, the primary problem is the patient reaches a heart rate. By the time they transfer over to the bed, their heart rate drops. So people thought, okay, well, maybe we can give them atropine when they're at their peak. By the time they transfer, they'll maintain their heart rate and we can get the pictures. Unfortunately, even despite giving them atropine, their heart rate still declines very rapidly, and all they end up with is side effects. So the ASC specifically just says, atropine is not recommended for exercise testing. You can still use it for dobutamine in certain cases, but for exercise testing, they don't recommend it. Okay, and then the other form of stress is, of course, pharmacologic stress. So it's the most popular one in North America is the dobutamine protocol, where every 3 minutes or so you go up on the dobutamine infusion rate, so from 5 all the way up to 40. And as I said, you can use atropine at the very end if you're just shy of the target heart rate. Low dose versus high dose is helpful for viability, as I'll talk about in a second. Atropine does increase sensitivity and the ability to reach target heart rate in dobutamine stress echo, so it can still be used. Just keep in mind that you want to use a lower dose of both atropine and dobutamine in certain patients, particularly the elderly. If they have low BMI, you may not need to give them as high a dose of atropine. If they have neuropsychiatric symptoms, you got to be a little bit more cautious. And of course, if they're very, very close to the target heart rate, you probably don't want to give them very much. Actually, you could get away with half a dose and try that out first. Just some quick tips on dobutamine and even, particularly dobutamine stress echo. If the patient is on a beta blocker, you want to make sure you hold that for 5 half-lives. So, patients who are on bisoprolol, for instance, that's quite a lot of days. So make sure that you're trying to do that. That's typically a bit challenging to achieve, practically speaking, in certain patients, but that's the gold standard. You may give beta blockers for patients who have completed a dobutamine stress echo as a way to reverse that. And there is some evidence that beta blocker use after a patient has achieved target heart rate can then induce ischemia and then cause wall motion abnormalities. And I'll talk about that as an example in a bit. And then just keep in mind, dobutamine is an inotrope. It can cause minor arrhythmias. But most of those arrhythmias, like atrial ventricular PVCs and things, will just resolve on their own. You usually don't need to give a beta blocker for that. Sometimes, if it really persists or it's recurrent, you can give beta blockers. But if you do end up in a situation with dobutamine where you have sustained ventricular tachycardia, that should raise a red flag. That's probably ischemia and not the dobutamine. Okay, so types of stressors. We've kind of talked about this already, but basically treadmill, bicycle, dobutamine. Depending on what you're looking for, you can use different types of stress. So for chest pain, you can use, in general, you want to try to use exercise stress test because that's more physiologic rather than dobutamine, but you can use dobutamine. Viability has been better validated for dobutamine testing because of low dose versus high dose response. Preoperative assessments, often those patients are quite unwell, so dobutamine may be the better choice. And then we're not talking about it so much today, but valve disease and pulmonary hypertension, you want to use bicycle stress because then you can take more pictures throughout the protocol rather than treadmill and dobutamine. Probably not the ideal setting for that. This is directly out of the ASC. It's a summary of the testing modalities and how to compare and contrast them. I just want to draw your attention to the hemodynamic differences. So with exercise stress, you have an increase in your oxygen demand, you have a dramatic increase in your heart rate, your stroke volume, your systolic blood pressure, and your contractility. You obviously increase your blood flow, and that's the most physiologic response that you can get. With dobutamine, it's not quite the same, but it's similar. So you do have an increase in your myocardial oxygen demand. You do have an increase in heart rate. Your stroke volume may not actually change or may even go down because of a decrease in preload. Your contractility goes up dramatically. And your systolic blood pressure tends to go up a little bit, but not nearly as much as in exercise, which is why it's not quite as physiologic in its response as if you had put the patient on a bicycle or treadmill. Vasodilator, I'm not going to talk too much about this today, but vasodilator is another possibility that you could use. It works in a different capacity. It increases coronary blood flow directly by increasing coronary perfusion. It doesn't really change your stroke volume, and it doesn't really change your contractility, so it's not as physiologic and not probably the ideal test for CAD. Unless patients really cannot do the other two forms, then you might consider it. So what are some of the things that you want to look for? So at rest, this is again directly out of the ASC updated guideline. So for CAD, primarily we're focused on LV function and regional wall motion. But if you were looking for valvular abnormalities or diastolic dysfunction as an early marker of ischemia or an early marker of symptoms of dyspnea, for example, then you can look at E over E prime changes. You can look at ischemic MR and whether that's getting worse with workload. You can look at pulmonary systolic RVSP, essentially systolic pulmonary artery pressure. That could be a marker of also decompensation from the left side, or it could be a sign of symptoms of dyspnea, again, as a result of pulmonary hypertension. And then RV function is an increasingly important factor as well. So looking at RV function globally or even more specifically can sometimes help identify RCA disease. So that's another factor that they recommend looking at. The middle two are specifically just for the bicycle protocol with the intermediate type of stress. But in treadmill, we're largely looking at rest and then peak, LV function, or regional wall motion abnormality. And again, remember, the recovery part is also an important part of the test. So just repeating all of those parameters once the heart rate has come back down. What are some of the endpoints? So we spoke about this already. So if the patient achieves that 80 to 85% of the predicted workload, if they have clearly abnormal ECG changes or obvious echo changes, or if they're significantly symptomatic, whether that's angina, shortness of breath, pre-syncope, signs of hypoperfusion, extremely severe hypertension, or hypotension, even more importantly, a drop of 10 or more, or if they have significant arrhythmias, those are all reasons to stop the test. And then abnormal tests, I'll just talk about in the next slide. But the protocol begins by doing a baseline echo. We're not going to spend too much on this, but basically just a quick assessment of LV function, chamber sizes, wall thickness, the standard views of peristernal, and then apical 4, 3, and 2 chamber views. It's important to do the baseline also because you want to rule out certain conditions that might preclude the patient from doing a stress test, like dissection, HCM, pericardial fusion, those sorts of things. And then also to ensure that the patient doesn't have significant valve disease, like they don't have AS that was missed and it's super severe, and now you may not want to do the stress test as originally ordered. So that's one reason, and of course you also want it as a comparison for the peak images. Just a quick note about some of the things that ASCU also identified. They do talk about how most often we use one cardiac cycle for stress images. That's largely based on just the software that's embedded in the stress echo machine, where they take a whole bunch of pictures and divide it up into one cardiac cycle. They do recommend more than one cardiac cycle is actually better and improves accuracy, but obviously there are technological limitations for software that we use, and that's primarily because it can reduce respiratory artifact, arrhythmia, and translation motion of the heart. And you want to review more than one peak stress image for accuracy. So when you're interpreting them, you want to not just look at the one, but all of them. So let's see if these videos are working. This is just an example of a completely normal stress echo, where you can see with stress, I'm just gonna have to keep clicking this. As you can see with stress, the cavity gets smaller and you have lots of thickening at peak stress in comparison to the baseline, which is the first image on the top left. So stress-induced ischemia can present as either regional wall motion abnormality, where you can go from normal to hypo to akinetic or even dyskinetic. You can have tardikinesia, which is just a delay and a slow segmental contraction. You can also have chamber dilation, and of course, an overall drop in your LV ejection fraction would also be a sign of ischemia. The chamber dilatation is usually a visual assessment of the LV chamber as a whole. And that's what we generally call transient ischemic dilatation, or TID. I think this is pretty straightforward and kind of, so I'll skip over this in the interest of time, but basically, depending on which view you're looking at, there are different coronary territories that correlate, and you want to try to correlate the territory in the various images to identify which blood vessel is most likely involved in the abnormal findings. Okay, so this is just an example of abnormal stress echo. I don't know how well it's projecting on the screen here, but if you compare the anterior to the inferior, it doesn't really contract quite as well, and unfortunately not projecting as well. I have some better examples coming up, so I guess we'll skip this one. Oh. This here is actually it's annoying that it's not projecting as a loop, but I just wanted to focus on the basal segment here. It looks like it may be a little bit hypokinetic. It's often overcalled, and it's just the importance of looking at whether the wall itself is thickening and not just focusing on the motion alone. And if the wall itself is thickening, as you can see behind my cursor, that the wall is thickening underneath, that is what you want to look for in the basal inferior segment specifically, or the basal inferior septum, because that's often overcalled as a hypokinetic region. But if there is thickening, then it's likely normal, and it's a very common false positive finding. The other thing that's really important, the ASC has talked a lot about in their guideline, is the use of ultrasound enhancing agents. So they recommend the use of this whenever there are two or more contiguous segments that can't be visualized well. And the administration of that should be sufficient to pacify the entire cavity without any swirling artifact in the apex or attenuation of the basal segments. And so when we think about, on the left, a example where there's no contrast used and it pretty much looks relatively okay, maybe some subtle findings, but relatively okay. And then if you look at it in contrast, you can see the walls much clearer, and you're just a lot more certain about the findings that you have. And in this case, you can see that this wall here is a little bit more hypokinetic, but in general, the fact that your conclusions can be a lot more solid. And I'm sorry that my loops are not looping here. Okay, so this is just an example also from the ASC, talking mostly about the harmonics here. You can see without contrast, you can barely see the walls. This is now using ultrasound enhancing agents. This is at a low MI index. So you can see there's a little bit more basal attenuation here. You can see the apex relatively well, but the basal segment's not quite as clearly. If you drop that MI index further, they recommend less than 0.3 and sometimes even lower. You can sometimes unveil those segments a little bit better. So playing around with that index can also sometimes help. And these images were all taken within 5 minutes of each other. So you can see that depending on the index, your conclusions can be much more sensitive and accurate. So these are just images, again, of patient at rest versus at stress. And again, that septum here is, okay, it's not playing at all now. There we go. If you look at the, Jesus, that's it. If you look at the left side, the infro, the three-chamber view. So if you look at the infralateral wall, it's contracting quite nicely, but the anteroseptum is not in comparison. Let me see if it works. I don't know if you guys can see that. It's a bit here. I don't know if you guys can appreciate that. It's not projecting that well. Sorry. Okay. What's that?
It's just like
okay, I just wanted to talk about some of the types of responses. This is most important for dobutamine here. The idea that depending on the baseline, if you have what you think is a normal kinetic, and at low dose dobutamine, if you see a slight increase in the motion versus at peak dose, you see a further increase in motion. That suggests a stunned myocardium, where the vessel itself is open. It's just that the myocardium is a bit stunned from prior ischemia. So as you give them more dobutamine, it contracts a bit better, and then as you increase the dose of dobutamine, it contracts even better. So that's what we refer to as a stunned myocardium, and that contrasts with hibernating myocardium, where there is a significant ischemia still. There's a significant stenosis. So when you at baseline, it doesn't move very much. When you increase the amount of dobutamine, there's a slight increase in the amount of flow, and the wall seems to contract better. And then when you increase dobutamine even further, you have even more contractility, but you also have more ischemia. And because you have more ischemia, the amount of wall motion actually decreases. And so that's what we call the biphasic response. And that refers to a hibernating myocardium, which is different from a stunned myocardium. And hibernating myocardium is important to identify because it relates to, because you're basically finding hidden stenoses, which need intervention, as opposed to stunned myocardium, where there is no significant stenosis. So as you increase dobutamine, the wall motion continues to increase. Just a quick note about wall motion during recovery. There were some studies, and there was a study done by Matthias and colleagues that demonstrated that when you inject beta blockers at the end of a dobutamine stress echo, you may actually identify new wall motion abnormalities.
Attention, code blue, 3 cardinal corner door, BT, room 2.
So some of the explanations for that might be that when you inject dobutamine, you block all the beta blocker. Sorry, when you inject a beta blocker, you block the dobutamine's action on beta 1 and beta 2 receptors, and you have unopposed alpha vasoconstriction, which then increase the afterload and then increase the amount of ischemia. Another possible explanation is that when you give the beta blocker, the adjacent segments are all contracting less now, and then you have better visualization of the truly ischemic segments. And the third explanation is maybe you're now identifying stunned myocardium, and that's different from something that you would be able to identify at peak stress. So various explanations. We don't fully understand it. Okay, quick note on RV function assessment. So the RV free wall should be included in an apical 4-chamber assessment. As I said, if you look at the RV wall and you notice that there's a decrease in the RV function with stress, and that could identify patients with RCA disease. The other helpful feature is to look at the tricuspid annular motion of over 4 millimeters with exercise. And if that change is present, then again, it could suggest proximal RCA disease. And so this is an example of that. I don't know if you guys can appreciate it there, but here, if you look, this is rest on the left and peak on the right. And if you see there with stress, the RCA is hypokinetic throughout this segment over here. With peak, but it's not as bad at rest. So this is a patient who had proximal RCA disease when they ended up cathing them. Just some important other parameters for early detection of ischemia. You want to assess diastolic function like mitral inflow and E and A velocities, and that has been shown to be an early marker of ischemia. You can look at E prime velocities. You can look at TR as a peak velocity, all as an assessment of diastolic function. And then if the patient has ischemic MR, then if you put them on a stress echo and their MR severity gets worse, then that could be a marker of ischemia as well. Some comments about blood pressure response to stress. So the updated cutoffs in the new ASC guideline for exercise stress echo is just a systolic blood pressure of 220. They don't really make a distinction between males and females there. And then for dobutamine stress echo, the cutoffs are 182 for systolic blood pressure and 96 for diastolic blood pressure. So much harder to remember. We might just have to screenshot this and keep it for a quick reference. Some other interesting points that when I was reading the guideline, which I had definitely thought about in the past, was that when patients have a hypertensive response to stress, it was always believed that that reduces the specificity for stress echo. The ASC guideline talks about how they reviewed a whole bunch of papers, and largely this has been debunked, and that hypertensive patients or a hypertensive response does not increase the likelihood of having abnormal ESE findings compared to normotensive patients. And patients who have a hypertensive response, particularly during a dobutamine stress echo, were more likely to have a stress-induced myocardial ischemia compared to those that had a normal blood pressure response. So ultimately, the take-home point is that patients who have a hypertensive response to stress should be evaluated just like any other patient who have a positive stress echo finding. So take the positive stress echo findings seriously and don't attribute that to the hypertensive response. In other words, the specificity does not change. That was interesting. I didn't realize that. Some other important points as well I wanted to make about false positive stress tests. So this is in patients who have a positive stress echo, but a negative angiogram. So the outcomes of these patients who have a false positive stress test were found to be quite similar to truly positive patients. And that's also a bit of an alarming finding. And this comes from a bit of an older paper by From and colleagues that looked at 1,500 patients or so who had an abnormal stress echo who underwent coronary angiography within 30 days, and they looked at the death from any cause. All of those patients had less than 50%, or I guess the intervention group or the important study group had less than 50% stenoses compared to the control group who had over 50% stenoses, and found that when you look at their all-cause mortality within 30 days, it was no different for patients who had a false positive test and had less than 50% stenoses when you compared it with patients who had significant obstructive coronary artery disease. They hazarded some guesses and hypotheses of why that might be the case, and they thought that the likeliest explanation is probably that those patients have abnormalities in that coronary vascular tone, whether that affects the large epicardial coronary arteries or the microvascular coronary circulation. They took a subset of these patients and did vasoreactive testing on them, and actually found that a lot of those patients had coronary vasospasm, which was undiagnosed, and the only presentation of it was this abnormal stress echo, but in angiography, it looked okay. But when you did reactive testing, they actually had vasospasm, and those vasospastic changes were bad enough that their overall mortality was pretty similar between obstructive disease and non-obstructive disease. So again, important finding that if you have a false positive stress test, they should receive intensive risk factor management and very careful follow-up, and not to just think that they are low risk. And then some negative prognostic factors to keep in mind when interpreting these tests. If the patient has a resting EF that is already low, less than 35%, that's a higher risk or a negative prognostic factor. If they get ischemic changes at a low low dose of dobutamine, or at 70% or less of their heart rate max, that means they have very easily inducible low stress and ischemia, so that's high risk. If they have significant wall motion abnormalities, which is defined as a wall motion stress index on effort of over 1.4 or 1.7, that would indicate high risk stress test. If they have extensive ischemia in 3 or more segments, if they have ischemia in multiple blood vessel territories, those are all high risk features. If their EF drops to less than 45% with stress, or drops by over 10%, or if they have transient ischemic dilatation with stress, all of that are high-risk features. If they can't even achieve their target heart rate, that indicates poor exercise capacity, and chronotropic incompetence also indicates that they may have really significant ischemia, and so they're really not able to mount a response and get that target heart rate. All of these should raise a red flag in your mind and make you think about this being a high-risk patient. Okay. So here, this is actually an example of transient ischemic dilatation with stress. So if you look at normal here, where this is a patient at baseline, might be a little bit difficult to appreciate, but typically, especially if you could think about how when the normal response to stress would be for a dramatic decrease in their cavity size and a lot of hyperkinesis of all the walls. In this case, you can clearly see a lot of the walls in the apex, the anterior wall is all down, and the overall cavity size, at the very least, even if you don't think it's bigger than the left, although it is, it looks pretty similar, which is also a red flag. Okay, because with stress, you should have a dramatic decrease in your cavity size. So this is an example of TID. This here is, just wanted to keep clicking now. Yeah, to keep clicking. Help you with this. Yeah. This is again also an example of dilatation with stress. As you can see there, Dr. Chow is pointing it out nicely for us. But basically, the cavity size is not getting any smaller with stress. Again, high-risk feature, TID, should red flag for significant ischemia, could even be multivessel. Yeah, it could be, yeah. But there is some territoriality into this. The anterior is worse. You can see the short axis in comparison to the inferior. The anterior is much worse. This patient ended up having proximal LAD disease, but also had some disease in the circ. Okay. And I just want to make sure it's projecting well. Okay. It's not quite a great example of the high-risk features here, but these are also some wall motion here. They're a bit more subtle, but here the basal segments are a little bit worse. Yeah, I don't think it's projecting quite as nicely here. Yeah, and you can see the inferior basal segment is there. But what I want to bring your attention to is here again, it looks like this inferior segment is again often overcalled. And so what you're trying to focus on is whether or not that wall is truly thickening, or is it just hypokinetic, or is it truly thickening? And here there are some signs that it might actually be thickening. So this is actually a false positive stress test where the patient, they ended up calling it hypokinesis. The patient went for a cath and ultimately did not have any disease. And they attribute this negative, like they went back to look at it and they thought, well, maybe because it was actually thickening, there wasn't truly any ischemia. So just to be particularly careful of the basal inferior and the basal infroseptum, and to look for wall thickening. And if you truly do see an improvement in wall thickening with peak stress, it might actually be false positive findings.
So now I'll just quickly interject. This is the basal inferior septum is our enemy for stress echo, because part of it is we only capture one beat, and often you intermix that deal with the membranous septum, where it's a thinner part and there's not as much muscle. So sometimes it's very confusing. So that sort of leads to our interaction between the person who's actually doing the stress echo, have the probe in the hand, and the person who's looking at it, the interpreter, to be able to work interactively to try to tilt back and forth. So, one of the challenges that we have is many locations in the world only do stress echo by looking at it afterwards, by making a report. And it becomes very difficult because if you only have one beat and try to make that interpretation without the panning and interaction and the assessment of the three-dimensionality of it, becomes a very easily create a false positive study. That's why in our institution, since the beginning of time of doing stress echo, we always emphasize having someone in the room who is the interpreter to be there. In fact, way back when, we used to do this by video tape. So with video tape, we usually go back and forth. Actually, you have a lot more images to be able to do it. And taking a lot of images in the background is also very helpful as well, because you can have multiple loops. And I think, we do it very well here, but many institutions do actually only read from one frame, which I'm very afraid of, creating false positive studies or false negative studies for that reason. Okay, moving along.
Yeah, just a quick comment also about stress echo in patients with dyspnea as their primary reason for being referred to us. This is also an interesting couple of studies that were done that found that patients who actually present or were referred for dyspnea and undergo a stress echo actually have worse outcomes than patients who are referred specifically for chest pain. And when you look at that, when you look at this graph here of patients who present with dyspnea and undergo exercise echo, their mortality rates are much higher than those who are referred for chest pain. And if you look at the amount of ischemia in patients, again, referred for dyspnea versus for chest pain, their ischemic, the amount of ischemia that they have is significantly higher than those referred for all comers for chest pain. So all of this to say that stress echo is actually very helpful in assessing patients who are presented with, who are referred for with undiagnosed or not fully elucidated causes of dyspnea. And that should also, this study, I think for me, it's just helpful to remember that patients who refer for dyspnea, I gotta have a high index of suspicion. And also that stress echo in particular can be especially beneficial in assessing these patients, not just in understanding ischemia, but also at looking for things like diastolic dysfunction, exercise-induced pulmonary hypertension, exercise-induced valvular changes, all of which could be a reason why they're becoming dyspneic with exercise. So exercise stress echo, I think, is a very, very helpful test in patients who have unclassified exertional dyspnea. And so the ASC talks about how ESC and DSC are appropriate and in fact recommended for those presenting with exertional dyspnea. It's a class 1 indication. Also, a quick comment about patients with left bundle branch block. The only reason I bring this up is because often we identify them as being difficult to evaluate. Their GXT is non-interpretable. So sometimes these patients get sent for exercise nuclear testing, but keep in mind left bundle branch blocks can cause a artifact in nuclear testing in the septum. And so unless you have very experienced nuclear readers, sometimes that can be overcalled and end up with unnecessary testing. Whereas with stress echo, the fact that we can look at wall thickening and overlook the desynchronous part of it and still look for other signs of ischemia, stress echo is particularly good at identifying ischemia in patients who have an underlying left bundle. So if you have patients coming through a clinic or hospital who have an underlying left bundle, maybe think about stress echo as the modality of choice. And some useful other things to know about stress echo and left bundle particularly, it's very useful for prognosis. The 5-year survival for patients who had an abnormal stress echo compared to those who had a normal stress echo was significantly lower. The MACE rates were twice as high if a left bundle patient had an abnormal stress echo versus a normal stress echo. And those that had a normal stress echo and their left bundle had a similar mortality to those who do not even have a left bundle in the first place. So very useful if you have a patient that incidentally has a left bundle, just get them to do a stress echo. If they have no changes and it's a completely normal test, then their mortality has been shown to be similar to a patient who had no left bundle in the first place. Useful clinical pearls. So again, ASC, class 1 indication for detection of ischemia and risk stratification for patients who have an underlying left bundle. Hopefully this works. This is a patient who actually has a left bundle at baseline, and so you can see that septum is desynchronous. I'll keep hitting the play, and Dr. Chow is pointing it out. But in this case, you can see that at peak stress, there is a little bit of thickening, but not nearly as much as you would expect. And this patient did end up having ischemia. But still helpful to know that difference there. Okay, so just to kind of summarize a few things here. The sensitivity of stress echo is about 88%, and the specificity is about 83% for the detection of coronary artery disease. The sensitivity specifically of stress echo is greater if the patient has multivessel rather than single vessel disease. That continues to be a challenge, which is why important factors like assessing RV specific images for RCA disease is useful to keep in mind. Also, the advent of LV strain and those sorts of things are improving our sensitivity and specificity, even for detecting single vessel disease. The sensitivity for stress echo is at least equal to nuclear, but it has higher specificity than nuclear testing for coronary artery disease, particularly when it comes to left main or multivessel coronary artery disease. And with that, I'm happy to take any questions. I apologize for my loops not playing continuously, and unfortunately the examples weren't as great as I hoped. But I'm happy to answer any questions and go back to any of the loops if anyone's interested.
Anyway, we all learn from our own technical challenges over the years. So it's part of our growth. And so I want to thank you everyone for joining in this beautiful presentation. And whole morning, we have, at the peak, there was actually 54 remote participants.
Oh, wow.
And these could be actually labs with multiple people. So together with all the people in the room, we actually have 70 to 80 people actually joining this round all at the same time, showing how our hybrid method actually can involve a lot of people. So I'll just start with the questions, and people are interested can come in with the questions through chat as well as opening your microphone. My first question is, you mentioned about shortness of breath being a very important indication for stress echo. Should we do routinely diastolic assessment? For example, E over E prime, as you have suggested. You see it?
So, I mean, I'm just quoting the ASC guideline. I got to be careful with how I word this. I think if the primary suspicion is that this is a diastolic problem, let's say the patient has signs of some diastolic dysfunction and baseline echo, or they have a clear history, and you've ruled out all the other causes of exertional dyspnea. So no pulmonary disease, no other potential causes. I think it's a useful thing to keep in mind. Of course, that means that you need to go through a bicycle protocol just to understand the different, just to be able to get all the images well enough. But the AAC does recommend us assessing diastolic dysfunction as a way. Now, whether or not you need to apply to all patients, I think is a clinical judgment for how high your suspicion is. Okay, I think Fody has a...
So maybe I'll just say that, this is new actually, the E over E prime that has been discussed for a number of times in the past. If you actually look at previous stress echo, Dr. Negwa has actually put in the diastolic section into the stress echo discussion, but never made it actually out to E over E prime until this iteration. Mm-hmm. And the other interesting discussion is using lung ultrasound in addition. As you know, Dr. Goffi and groups from Italy has looked at this, but we tried it here, but we didn't have much positivity of it. So we dropped it after trying it for about 3 months, but that was actually described as part of the evaluation of the shortness of breath with exercise. So those are answering methods in case you have patients who have actually shortness of breath and you can't figure it out.
You can't figure it out.
So it could be like diastolic dysfunction with exercise. So Foti has a question.
Yes. So Fody has a question. I'll just read it out here. What do we do with patients who have a positive GXT but who have a negative echo, a negative stress echo? The ischemic cascade would suggest that they should have wall motion abnormalities before ECG changes. How do we marry the two concepts? And he's helped me out by saying it's a tough question, which it is. Well, I'm happy to actually, I'm happy to take anyone else's opinion on this as well. I think, I'm not really sure. I've obviously limited experience with this, but we do know, I think it's pretty clear that their outcomes of patients who have a positive GXT and a negative echo are definitely worse than patients who have a negative GXT and a negative echo. But how much higher their risk is and how does that compare, and what are some ideas of maybe identifying ischemia that we're missing with the wall motion abnormality, I think is a important frontier of research. I think there are some new and upcoming things like the use of strain, for example, may help improve our sensitivity for detecting maybe ischemia. But I think that's still in its advent. So any of the speakers who have more experience with this, I'd be happy to if they could weigh in and help us out.
Yeah, so thanks, Ashwin. So I'm going to add, I'm not sure if you can hear me, but so the issue is the issue of the positive ECG and the negative echo, I think it's not binary. I think there's lots of nuances to it. So I think there are a subset of patients who definitely have false positive exercise ECG. I think you have to be very confident that the stress echo component is truly normal. I think we all recognize where a stress echo is completely normal. You see all the segments, there's hypercontractile function, the cavity is smaller. And usually the positive ECG is not that significant. So you just have to be careful about over-calling on the ECG side versus actually under-calling on the stress echo. You mentioned about the specificity of echo. We're very specific when it comes to stress echo. We want to see that definitely wall motion abnormality. So it's possible that we're missing subtle abnormalities. So for me, it all depends on the pretest part. The pretest probably is low, stress echo images are fantastic. ECG is not that striking, then I would say it's a false positive stress echo, and I would just continue managing the patient. If it's the opposite, and the ECG findings are striking, but the echo images are challenging, so then I would go on to the CT angiography or others tests. And then the intermediate is somebody with risk factors that probably deserves to be managed. Positive ECG, pretty negative stress echo, I would just manage the medical. I think that's probably the safest thing. So it's a big spectrum.
I would agree with that. And it's also the clinical acumen. So we can't just blankly plus or minus. So I think we're just going to take one last question. It's 9 o'clock. Some of our colleagues have to get back to work. But we cannot pass this question from Saudi. So thanks for joining us all the way from the kingdom. And this question is about coronary stress echo in patients with left main lesion. Do you think it's risky? Kind of. This is why there's a rejection of this method to roll out active ischemia by some of my colleagues. So you want to comment on that? So my opinion is, if you know the left main already, then you don't need to do the stress echo. Often we do the stress echo to find out the left main. It is a very useful method. Sometimes what happens is when you do nuclear study with the balanced ischemia of left main or severe pre-vessel disease, I have come across, and the literature also suggests that you could have false negative from the nuclear, and the ovarian stress echo tend to be more sensitive for those type of cases. So I think, again, one of the contraindications about doing stress echo is active ischemia, and so I think that helps that answer that question. So once again, thank you for joining us from all over the world.